Good afternoon to everyone. For those of you on the East Coast and for those of you on the West Coast joining us for today's webinar, pleasant good morning to you. My name is Dr. Astral Webb, and I am the Director for the National Center for Health and Public Housing here at North American Management, and we want to welcome all of you to today's really exciting topic. The topic is entitled Oral Health, Putting a Smile in Public Housing. And we are truly delighted today to be receive information from 3 distinguished, engaged, and dedicated dentists who are working to improve access to quality oral health across the country. So we would like to let you know that our panelists for today's webinar presentation include Dr. Lynn Douglas Mouden, who is the Chief Dental Officer at the Centers for Medicare and Medicaid Services. He has also worked formerly with the Missouri Department of Health and Arkansas Department of Health, and he holds multiple faculty appointments at the University of Tennessee College of Dentistry and University of Arkansas Medical Services. He has received numerous distinguished and recognition awards for his work in oral health advocacy and other related issues. Our second presenter today is Dr. Hilton. Dr. Irene Hilton is a staff dentist at the San Francisco Department of Public Health, and she is a dental consultant for one of our national corporate agreement partners, the National Network for Oral Health Access. This national organization represents dental providers working in health centers. She has over 25 years of clinical experience in working in the safety net environment, providing oral health care to age and ethnically diverse populations. And our third panelist is Dr. Sam Wakim. He is the director at Sioux Falls Health Centers, which is one of HRSA's grantees. And Sioux Falls, under his leadership, has provided an integrated primary and oral health care program that is very, very innovative, especially in providing oral health access to care for residents in public housing. So we know that all chronic diseases start with good oral health. So today, from all of our panelists, Dr. Hilton, Dr. Mouden, and Dr. Wakim, you will hear general information regarding oral health care for residents in public housing. You will learn about the role that CMS, the National Network for Oral Health Access, and health centers in general are doing to have on proper oral health care resources and access, education, as well as some understanding of the reimbursement rates available for you. Our objectives are to talk about some of CMS oral health initiatives, to highlight some of the goals that CMS would like to see implemented in your states for dental care, and the impact of savings when these goals are met in health centers across the nation. You will also learn about Medicaid reimbursement rates for oral health care for residents in public housing, and education and resources for those grantees regarding oral health care. So without further ado, I would like to thank all of our presenters today. We will hear first from Dr. Mouden, followed by Dr. Hilton, and then Dr. Walkin. So Dr. Mouden, thank you for joining us.
Okay, thank you, Dr. Webb. Good morning and good afternoon to everybody on the call. Certainly is a pleasure to be with you today to give you some federal perspectives. And I will go ahead and say that my federal perspective is only this year. Previously, I was in private practice and then worked in public health for 22 years at both Missouri and Arkansas, as Dr. Webb mentioned. So I just want to give you an idea of what's going on at the federal level and what we can do to support what's going on in the states, and especially in FQHCs and in public housing. To give you an idea, we'll do a little CMS 101. We are the Centers for Medicare and Medicaid Services, and the aim for CMS is to be the major force and a trustworthy partner for the improvement of health and health care for all Americans. Some of you may be familiar with Dr. Berwick's triple aim, which is the basis for what we do at CMS, is to improve health care, and reduce costs. Now, CMCS is the Center for Medicaid and CHIP Services, where I'm located. We move the mission forward with emphasis on Medicaid and CHIP. Beneficiaries are our focus, and I'll have to tell you that's a term that's relatively new to me because I still think of these people as our patients. And we are obviously aware that partnerships are critical to the success of everything we're doing at CMS. So I want to give you an idea of who we are and who we deal with, how many folks we are talking about that are covered under Medicaid and CHIP, and the various responsibilities involved in moving Medicaid forward. To give you an idea, and I will have to admit to you some of these numbers are a couple of years old, and sometimes they're the best we have. When we're talking about the population in general, we can talk about those that are covered by employer-based insurance. And of course, we all understand there's really not dental insurance, but prepaid dental coverage. Those that are uninsured. Now, if you look at the pie chart on the right, you see who is being covered for those children below 133% of the federal poverty level. And you can see that Medicaid and CHIP take up by far the largest part of that. And of course, as you know, as you've been keeping up with the news, with the Affordable Care Act, portions of which will, the major portions of which will begin in 2014, these numbers will continue to grow. Medicaid and CHIP are a federal-state partnership. So I not only want to explain what each of our responsibilities are, but also give you an idea of some of the limitations we have on each side of the equation. At the federal level, we have statutory and regulatory requirements. Medicaid and CHIP come down from Congress, and from that we develop regulations and rules that move the statutes forward. The federal government provides what's called a FMAP, which is the federal matching funds that match what the state puts into Medicaid. Now, the FMAP is different based on income levels and per capita income in the various states. So the matching funds can be as low as 50%, so a 1-to-1 match, or as high as 76%, which becomes a 3-to-1 match. At the federal level, we approve every state's Medicaid state plan, and under various programs, numbers you may have heard like 1115 waivers, those are ways that states can change, not only make amendments to their state plans, but also suggest other ways that they can increase access to care, improve health without additional funding, and those are done under waivers, which are essentially demonstration projects that allow the states to change things somewhat to get better outcomes. And then obviously we provide oversight to the states. Now at the state level, they determine who is eligible. There are optional services, and we'll talk about optional dental services here in a minute. They also have the flexibility to determine the delivery system. In the beginning, all Medicaid was paid on fee-for-service, and now, as I'm sure you're well aware, much of Medicaid in many states is paid through managed care organizations. The states determine how Medicaid will be administered and how claims are paid, and most importantly to many providers, it's the state that sets the payment rates. The reimbursement rates are not set at the federal level, and each state has to make determinations based on their own budget what they're able to pay as reimbursement for dental services. So we have two different programs we're talking about. One is Medicaid, the other is CHIP. CHIP is the Children's Health Insurance Program. Under Medicaid, children are to be provided all medically necessary dental care under the Early Periodic Screening, Diagnostic, and Treatment Program, otherwise known as EPSDT for obvious reasons. There are no hard limits allowed in Medicaid. There are some soft limits, we call them. For example, prior authorizations for certain types of treatment. Cost sharing is not allowed in the Medicaid program. CHIP, which is based on a different income level eligibility, has a slightly different definition of the things that are to be covered. And frankly, I find it to be an excellent definition because it talks about all dental services necessary to prevent disease and promote oral health, restore oral structures to health and function, and to treat emergency conditions. A little misspelling here. There are annual benefit maximums allowed, and prior authorization is also allowed. Under CHIP, there can be cost sharing, such as co-payments. Under CHIPRA, which was the Children's Health Insurance Program Reauthorization Act of 2 years ago, there are dental regulations, and the final regulations are still under development. So to give you an idea of further scope of dental coverage, Medicaid coverage for adult dental services is an optional program for states. It is not required. So some states are able to cover comprehensive dental care for adults under Medicaid. Iowa is an example that comes to mind with comprehensive adult dental benefits. Some states do provide a very limited scope of services under adult dental Medicaid. Some states cover only the very basic of emergency services, including some states that cover only life-threatening emergencies. So in many states, Medicaid adult dental doesn't really exist, unfortunately. Then for those over 65, and as I said in a congressional briefing a couple of months ago, I don't mean to be flippant, but it's almost as if we don't care about people's oral health once they turn 65, because with very few exceptions that are for inpatient hospital cases, there is no dental coverage under Medicare. So to give you an idea of how we track things at the federal level, each state is required under EPSDT to submit annually a form called the CMS 416. The 416 form is based on claims paid by each state, and you can see each of these different line items. What we ask the states to report to the federal government are the number of unduplicated children who were on Medicaid for at least 90 continuous days, any dental service, any preventive dental service, so there we're obviously talking about prophies and fluoride treatments, dental sealants, a dental treatment service, which means restorative, under 12D, a sealant that's been placed on a permanent molar tooth, and again, these are number of children reported. Dental diagnostic services, which are obviously exams and radiographs. And then a couple of newer ones, although the last 4 are all relatively new. An oral health service provided by a non-dentist or not under the supervision of a dentist. So this specifically includes physicians that may be doing risk assessment and fluoride varnish, nurses or PAs working under their supervision as well. Those, by our definition, are oral health services, not dental services. And then line 12G adds those two together, both dental and oral health services. So this is how we track what each state is doing, and again, it is counting the number of children, unduplicated children, that receive these services in a calendar year. So this gives you an idea on this bar graph what we're seeing on the use of dental services, and luckily has increased. And hopefully you're watching this in color. The lighter blue bars to the left are from 2000. The darker green bars to the right in each column are from 2009. And as you can see in each of the states, and they're divided by quartiles, everyone is doing somewhat better on any dental services. And you can see that the national average went from about 26% to about 40%, and actually the newest numbers are showing that that is about 46%. So these continue to improve. Another good news slide is that we see that not only are more and more children being covered under Medicaid and CHIP, but we're seeing more services provided. So the burden on the population is that we have more children eligible, and we are also even seeing more services provided. When you look at individual states, and I don't know how you have this showing on your screen, but each of the states is labeled. For those providing any dental service, these are the percentages. Goes from a low on the left side of about 23% to a high on the right side of almost over 60%. And you can see that there's tremendous variation from state to state. And again, these numbers show 2009, and we've had many of the states have improved considerably since that time. Then when we talk about improvement in the rate, so this is the change from 2000 to 2009. Unfortunately, over on the left side, you see the states of Nebraska and Florida. And if we have people on the call from Florida, I don't think they're surprised about what's going on. Florida's made the national news several times. Actually, where these numbers are a little worse over that 10-year time span. But by the same token, we have states like Maryland on the far right side, where their rate of improvement is over 250%. When we talk about the utilization of preventive dental services, and again, this was the line 12B on the Form 416 form, you can see that, again, we have great variation from about 15% all the way up to about 52% for the states providing a preventive dental service to these children. And again, we look at rates of improvement. Sorry, folks in Florida, you dropped way off again. And actually, the rate of improvement is a negative rate in that case. So moving right along, what we do see about the children receiving any dental service, again, Medicaid covering those children under age 21, we're doing a pretty good job on getting to the children in the middle age ranges, especially 6 to 9. And of course, we're hoping that those are the children that are receiving dental sealants. But you see that we obviously don't do much about dental services for those under 1, but again, we would hope to see those numbers increase when we're talking about oral health services provided by non-dentists, specifically pediatricians and family practice physicians that may be doing risk assessment and fluoride varnish for young children. And then you can see as they become teenagers, we tend to lose them receiving dental services, and I don't think that is exclusive to the Medicaid population. Being the father of 4 myself, I know that sometimes getting the teenagers to the dentist is not the easiest thing to do. So we have what we call the CMS Oral Health Initiative. We have 2 goals. Goal number 1 is to increase by 10 percentage points the proportion of Medicaid and CHIP children who have received a preventive dental service. Now you'll note that says 10 percentage points. So if a state is at, for example, 20%, we want them to increase that to 30%. So that's not a 10% increase. That would be from 20 to 22. We want to see 10 percentage points. We are just now completing the baseline data that will be provided to each of the states, possibly yet within this month, so they'll know what their baseline is so they can be working toward their 10 percentage points increase by 2015. The second goal is to also increase by 10 percentage points the proportion of children ages 6 to 9 who received a dental sealant on a permanent molar tooth. Now, we've not yet set the baseline. This information reported to CMS is relatively new, and we're waiting until we get a better handle on what the baseline is. So that'll be reported to the states before too long. So what is the state obligation under Medicaid? First of all, to inform the families. This is a statutory requirement, so the families know what's available. States are required to facilitate the access to care, hopefully linking medical and dental providers, providing help with referrals and making appointments, providing transportation, and hopefully ensuring that required services were obtained. Under statute, it says they are to pay adequate reimbursement rates. And again, that is always up for discussion, and reimbursement rates are set by the states, not the federal government. And then, of course, the requirement is to report this to CMS, again, on the Form 416. The other thing that they are to do is to increase provider participation. And these are just some of the examples that states have done to make it easier for dentists to actually participate in Medicaid and CHIP. Making provider enrollment easier, providing easier confirmation of eligibility. So when a patient walks in the door, you know that they truly are or are not on Medicaid. To use ADA procedure codes, which are kind of the universal code set under the CDT. Electronic filing of claims, prompt payment of clean claims, try that again, clean claims is always important. And reducing prior authorization requirements. It's kind of a joke, but we obviously don't want somebody to have to go through prior authorization to get a dental sealant. Provider hotlines are very effective, as are the dental advisory panels in states that have that. So what is our strategy? It's to work with the states to develop oral health action plans to help them meet these two initiative goals. We provide technical assistance to the state and connect states with model programs that have made great strides in addressing these different issues. We work on both outreach to providers and the patients, and working with other HHS, that's Department of Health and Human Services agencies. And as you can see, there is a CMS oral health strategy, which is available on the website. I'm not sure, but I'm hoping these slides will all be made available after the webinar, so you're able to click on that link. The state action plans that we've asked each of the states to do will give us an idea of how they are going to be addressing these two goals. We obviously want them working with the stakeholders in the different states, and hopefully that will include some of you. And they should be considering how they can align these efforts under the state action plan with other things. For example, the state oral health plan, which is most likely being done in the state health department or possibly through oral health coalitions, aligning their efforts with the Healthy People 2020 goals, and of course with the Maternal and Child Health Bureau Title V performance indicators. So we give them an action plan template, give them ideas on things that kind of give us a snapshot of what's going on in the state. You can see the different things that we ask for, and also talking about what they can do to address each of these areas as they move forward on their action plan. Obviously, none of these things ever happens in a vacuum. It's the state Medicaid agencies working alongside the federal CMS, working with dental schools, dental hygiene programs, working with state health departments, and working with providers, including FQHCs and public housing clinics. That is going to be really required to move the initiative forward and to provide access to better dental care for all of those that we care about. So I think we're going to be doing questions at the end of the webinar. So for that, I will turn it back to Dr. Webb.
Thank you so much, Dr. Mouden. What we will do is at the end of the presentations, we will take questions from the audience. And please, everyone, note that the slides will be available on our website following the presentation, and then audio version will be available within the next 48 hours. So I would like to introduce our next presenter, Dr. Irene Hilton. Dr. Hilton?
Thank you. Okay, let me, hopefully everyone can see my screen. Okay. Well, hopefully either if everyone can't see my screen or can't hear me, somebody can contact me on the chat room. So thank you all for coming to the webinar today. My name is Irene Hilton. I'm the dental consultant for the National Network for Oral Health Access. Let me explain a little bit about what NNOHA is. We are a national organization that represents dentists, more technical issues, that represents dentists that work in health centers and other safety net providers. We were established in 1991 by a group of dental directors that were working in health centers and FQHCs who realized that we needed peer-to-peer networking and support in order to be able to do the best job to provide quality oral health care to the people that we serve. And our mission is to improve the oral health of underserved populations through leadership, advocacy, and support of oral health programs. Okay, and we currently have about 2,400 individual members. Okay. Now I'm having trouble forwarding. Okay. A little bit about, let me just talk a little bit about health center programs. Okay. I'm having a little bit of technical difficulty here. Back. Sorry. Let me talk a little bit about health center dental programs. So like I said, health centers are nonprofit clinics that provide health care services, not just dental care, but also medical, behavioral, multiple disciplines to underserved low-income individuals, either with no insurance or with public insurance or limited insurance. And just some data about health centers. For last year, there were 1,128 health centers across the country, of which 76% offered dental services. The thing that people have to remember, though, in terms of access is that when you look at total capacity for 2011, health centers provided medical care and medical services to 17 million unduplicated users versus 4 million users of dental services. So the capacity itself within health centers for dental programs is currently not equal to the capacity of the medical side of it. And we see this frequently. For example, a health center could have 5 or 6 medical clinics and they only have 1 or 2 dental clinics. So that's one of the, again, even in the health center setting mirrors what happens in general in terms of people being able to access medical services better than dental services. If you look at the national public housing data, again, from health centers that are located in public housing, there are 61 grantees nationwide who last year served a total of approximately 187,000 patients. But you can see that if you look at the number or percentage of patients in public housing that got dental services, it actually mirrors the health centers as a whole, with approximately 43,000 or 23% being able to access dental services. So again, mirroring the capacity issues that we have with health centers as a whole in public housing health centers. So some of the challenges for residents of public housing who are trying to access oral health care. I mean, in reality, it's really similar to most low-income populations. And 3 of the additional, or I think more, well, some of the more, again, it's pretty much the same as in all, for all low-income populations, but certainly transportation. Even if you're located in a rural, in an urban environment, the public housing, could still be geographically isolated from other parts or from healthcare providers. Language issues, incongruency of the language capabilities of public health center population with provider population, and just navigating the system, especially for recent immigrants. It's very difficult to understand healthcare coverage, and especially dental coverage, even on top of just the medical. They're able to access medical services, but not dental. And there was a survey in Boston that showed that public housing residents were more than twice as likely as other city residents not to have had a preventive dental visit in the last 2 years. The insurance challenges, of course, and again, just like with other low-income populations, the lack of insurance options, especially when you're looking at the adult population. Dr. Mouden covered again how Medicare really only covers very defined oral health services for adults, and in Medicaid in the majority of states right now is not covering routine dental care for adults, the emergency care. And most of the states. And you can see it again in public housing. The major source for medical insurance is Medicaid, but that over a third of the residents are uninsured. So when you're looking on how to access or provide access to oral health care for clients in public housing, and let's say you're already in a health center or near a health center, these are just some of the broad categories. You can add a dental program to an existing medical provider. There's state and local resources. There's emerging work with interprofessional oral health competencies, and then workforce innovations. And this is just a potpourri of some of the things that can be done. One is if you have either a health center that serves the public housing population or nearby that doesn't have a dental clinic, then you can add a dental clinic, or you can start a dental program. For low-income populations, and these are just some of the resources. We have a manual, and then there's the Dental Net Safe Dental Clinic Manual, and the ASTD survey, for needs assessment data. Everybody's currently waiting right now at this very moment for HRSA to release new access point RFP. And again, if you have a health center that doesn't have dental, that's the way to fund it, and it's probably the most practical, from one perspective, because you're using existing infrastructure of a medical clinic that you could then add dental to. There's also, if you're not in a location, say you're in public housing that doesn't have any health center associated with it, in the local community, there may be other nonprofits, FQHC lookalikes like county health departments or other nonprofits that provide dental services. If you happen to live in a location that has a dental or a dental hygiene school in the vicinity, that's a potential resource. And then there's several local programs, especially for seniors. This is an example of the Senior Oral Health Project that is in the Boston Housing Authority. And hopefully these slides will be available so you can link to all of these, where they bought, like I said, screening and oral health services to senior residents in the Boston public housing. There's also, and honestly, maybe this does or doesn't say something about where we're at currently in this country in relation to oral health, but the Missions of Mercy and Remote Area Medical, or RAM, clinics that have been going around the country really are starting to be essentially a system of emergency care, especially, and I'm here in California. The Mission of Mercy has been now a collaborative effort with the California Dental Association. They're going to be doing 5 events a year in California, rotating different parts of the state. And basically this is the a consistent way that low-income adults can obtain dental services, even if it's mostly emergency, and some, restorative and rehabilitative. But again, since it's going to be regular, and again, not to make comments about where we're at in the state, but really this, again, if it's a regular service, this does become an option for how you can obtain at least emergency care for clients. Another emerging concept is the idea of interprofessional competency, which is the training of medical providers, be it physicians, nurse practitioners, or PAs, to be able to do certain oral health procedures, and basically screenings, which could be for oral cancer or early childhood caries risk, or for perinatal, and then be able to both do referral, but also can impart in the medical system self-management skills for controlling disease risk, and also administer fluoride, whether topical or prescription, that patients can utilize. There's also workforce innovations. Of course, this depends totally on the state that you're in. There are states where dental hygienists can directly access and see patients independently. such as Colorado, and they can come, using either permanent or mobile equipment into public housing and provide services. There's the Community Health Corps, and then in some states are doing projects, pilots with teledentistry. So again, having non-dentists go in and do the initial assessments and services, and then dentists able to bill afterwards using teledentistry to make the programs self-sufficient. Like I said, we we have access to many of the health centers throughout the country, and one of our main missions is to always, and not just in relation to public housing, but for many topics and populations that we serve, to assess what it is that our members are doing at the local level and best practices, and be able to collect those and disseminate those so that other people can learn and perhaps do a better or improve what they're currently doing. So we asked some of the health centers where we know the dental programs and that serve public housing, and just asked them to give us a little bit of input in terms of what they do, very brief, and then we're going to get a much more in-depth presentation in a minute about what they do and how they make their services, or how they make their programs, dental programs that serve public housing, work. And so here's two of them. This is the Heart of Texas Community Health Center in Waco, Texas. They've been a public housing grantee since 2007, and they target their dental service outreach towards children and pregnant women that live in the public housing. And they have a clinic. They have one of their medical dental clinics set up a few blocks from one of 3 complexes in Waco, and the clinic happens to be located between the public housing and the elementary school that many of the kids that live in the public housing attend. So they, the health center has utilized, they have 2 navigators from the Community Health Corps program. They're actually stationed at the housing complex that schedule appointments, and their data shows that over 80% of the kids that live in public housing get their dental care at the health center, and that they identified that their main challenge has been getting parents to better understand the importance of oral health care and going to visits. Another health center that we inquired about was the San Ysidro Health Center in California, and the same thing. They have a medical clinic in the public housing site, and so they send their staff over to do dental screenings and other services, or at the site, or to set them up at retail sites where public housing residents shop. And they have a mobile unit that goes to the housing sites that offers the medical and the oral health screenings, and they're getting approximately 90 patients per month from these activities. What they think that what works for them is that the medical provider that's in the mobile unit will personally say to the parent or pregnant woman that they strongly recommend having a dental appointment, that then the parent or the patient actually has a dental appointment back at the main clinic before they leave the mobile unit. There's free transportation from the housing unit to the clinic, and assuring that there's a short wait time between the time that they're seen in the van for the screening and the time that they actually have the appointment in the clinic. And for them also, the challenge is belief in the population that oral health isn't as important as the other healthcare services, such as immunizations, and that there's a lack of knowledge on how to navigate the healthcare system and the sliding scale for the patients. So that, I think, is actually my last slide. Oh, no, this is my last slide. Okay, so contact us. This is my information, my email, and you can go to our website, NNOHA.org, for lots more resources. And thank you.
Thank you very much, Dr. Hilton. And our final panelist is Dr. Sam Wakim, who is with Sioux Falls Health Center. Dr. Wakim?
Hello. Thank you very much, Dr. Webb, and thank you everybody for having me as part of this panel. I hope everybody can see my slides. I am Dr. Wakim, and I'm the Dental Director for Zufall Health Center. And I'm just going to tell you a little bit today about our health center, our patients, a little bit about our dental program, and our experience with public housing. So the Zufall Health Center is a federally qualified health center, and our mission is to provide quality, affordable care in a culturally competent way to our community in Northwest New Jersey, and we would like to eliminate health disparities and improve quality of life for our community. The Zufall Health Center was established in 1990 in a church basement in Dover by Dr. Zufall. He and a few of his friends who are volunteers decided to start serving people in the community, and the program grew, and the state got wind of it and supported them with some grant funding. And in 2004, we became a federally qualified health center, and we're now serving 4 counties. We have a couple of dental sites, but all of our sites will have dental in them within the year. In addition to the 6 sites, we have a mobile health van, which we use for dental care as well. We bring our portable equipment onto the van. We have a handheld x-ray machine with a sensor that's connected to a laptop that we bring onto the van along with other equipment to allow us to do exams and cleanings and prophies on the van. With that we find very useful, because it kind of eliminates transportation as a barrier for a lot of our patients, and it allows us to get into the different areas that we reach. Our patients in 2011, we had 15,000 patients with 45,000 visits. Most of our patients are below 200% of the federal poverty level. Most of the patients of the Zufall Health Center, about 70%, have no insurance. So even though New Jersey does provide Medicaid coverage for adults, the area that we're in, most of our patients don't qualify for Medicaid and just end up without dental insurance. They're just kind of stuck in between. 80% of our patients are racial and ethnic minorities, and most of them are better served in a language other than English. And the general distribution, we have more adults in our health center, but when we look at the dental numbers, we're pretty much evenly distributed between children, adults, and seniors. In 2012, we had 4,200 patients. We're on track to have a little over 10,000 visits. Like I said, a third of our patients are children, and within the past couple of years, we've been really trying to reach the young children, and we have 150 last year that were between the age of 0 and 3. And that's also greatly due to our partnership with Head Start. So the approach we take to providing dental care for our community is kind of, we try to take a public health approach and concentrate on forming long-term, sustainable relationships, using first our health van to reach out to areas where there's a lot of underserved patients, whether it be Head Starts or nursing homes or public housing sites or homeless centers. And we try to establish long-term relationships where we go on a regular basis and examine those patients, screen them, provide cleaning, fluoride, and kind of get them into the system. So we don't wait for them to come in and get the preventive care. We try to go out and get the preventive care, and we figure if we do it long enough, we will have a significant impact. And this has been very well received by our partners, and we've been growing the number of sites that we go to. Also, we support the schools. We do have school-based programs, and for some of the schools that don't have fluoride-based rinsing programs, we encourage them, and we even pay for some of the fluoride in those schools for the weekly rinsing. At our center, we do provide the basic preventive and cleanings and fillings. We do have most of what we do is dentures and single crowns. Our population in general can't afford to get complicated care, and very few patients need complex treatment, luckily, but those who do end up being referred, and it's a small percentage. So the way we get to see all our patients is by, because being a health center, we have to be efficient, and we have to serve a large number of patients. We're overwhelmed with the numbers. So in order to maintain our quality and provide care to a maximum number of patients, we hire some specialists to help us do that. So we do have a pediatric dentist on board. We have some periodontists who some of them do the surgical procedures, and we have somebody who's trained in providing care for geriatric patients. We have excellent assisting staff. We have students that rotate through the center, a lot of interns, and volunteers. Volunteers just never left the Zufall Health Center. They've been part of the center from the beginning, and they just continue to work here and volunteer, and it's great to see them and to have them. Our staff also receives training in public health and health literacy and humanism to make sure that we're caring for the patients and communicating with them in a way that they can understand. We work very closely with medical. We have a very close relationship, dental and medical, and we found that, for example, the HIV program has a case manager, and we find that whenever there's a program with a case manager, it helps facilitate things. There's follow-up and appointment scheduling, and it works very well together when we have extra support. So medical provides the dental department a lot of support, and we also participate in other activities like the Healthy Weight program, where the dentist and the dental assistants engage the patient in healthy weight activities. So our special populations, we have a few special populations, and they include the public housing residents. We also have programs for the homeless, farm workers, and veterans, and it's basically the same framework that we follow. Just trying to get the patients and provide the preventive services on site as much as possible, and then bringing the patients into the health center. In the last couple of years, the program's been growing, and we have a lot of sites. We had 4 main sites that were public housing centers. And in dealing with the residents of public housing, we realize that they have associated health effects with their housing, and we definitely see more blood pressure, high blood pressure in those populations, higher rates of heart disease, and injuries. And we do talk to our patients about, especially the seniors, about putting out a night light, during the night, so when they wake up, they're not tripping and falling. So we try to engage the patients very closely based on where they are. So for public housing, they have specific needs. The typical public housing patient for us is an average 69-year-old female with multiple medical problems. The lady on the right-hand side of the screen was basically the one smiling, basically stays in her unit all day long, and she came down to the unit. We did her dental exam, we did her cleaning, polished her teeth, and she got her healthy weight activity, and she was thrilled. So she ended up following up at the health center. And about 65% of the patients that we see on site do come back to the center. And like I said, the average age is 69. 30% of the patients we see on site are Hispanic, 17% African American, mostly female. It's a little bit different than the regular, our general population. So there's a, more white female characteristic. The public housing sites for 2013 were growing. The program was successful, and we're adding sites. And so for 2013, we have 10 additional sites planned that are interested in doing the same thing we did with the 4 other sites. So basically, these programs are all a little bit different. We try to give the partners as much control as possible and try to give them as much input as possible within the same general framework of providing the preventive services. So the challenges for us with providing care for public housing residents is that these residents are all in, that they receive the same water source. So water fluoridation, we're not fluoridated in most areas of New Jersey. We think that if we had water fluoridation, especially going to these housing units, we would have a significant impact in providing low-dose fluoride exposure and decreasing the caries rate. A health liaison, typically when we go to nursing homes, Head Start, or the schools, there's always a nurse kind of that we could have as a liaison. We don't have that in a lot of the centers that we go to, so we kind of partner with other organizations that provide services to residents of public housing and work with them on helping us advertise and reach those patients. The successes for us are the state support that we get, because specifically our health center has a lot of uninsured patients. We rely heavily on the state in general in supporting us, and they have been fantastic. The normal registration process for the health center is 4+ pages, and for all the programs that are off-site, they have given us an exception where we've condensed the registration form into a 1-page, and we could get the ball rolling and start engaging the patients on site. When they come back to the health center, then they fill out the rest of the information, but at least it gives them an opportunity to be exposed to our care and be seen on site and get preventive services. Medicaid reimbursement, again, we're lucky in New Jersey that we do get reimbursed for providing services for adults. It's a little bit difficult at times dealing with Medicaid HMOs and getting through the limitations and credentialing and things like that. But at the end of the day, we do get paid, and that's something that helps us be successful and sustainable. And then the most important measure of success for us is our patient satisfaction. And about 95% or more like our center. They think it's safe and clean, and they think the doctors speak to them in a way that they could understand, and they're happy with the quality of the care they provide. We've also been lucky to receive some awards, many at the health center, and we're grateful for that as well. So with that, that's my last slide. I'm going to turn it back to Dr. Webb.
Thank you very much. So I would like to, first of all, again, officially thank Dr. Lynn Mouden, Dr. Irene Hilton, and Dr. Wakim for such excellent presentations. We are going to open the line for some questions now. So if you would like to ask the presenter a question, please either submit it through the question box on your control panel, or if you would like to verbally ask the presenter a question, use the raise hand icon on your control panel, and we will unmute your line and give you the opportunity to ask your question directly. So, Devin, if you can just let me know if currently there are any questions in the queue, please.
I'll let you know as they come through.
Thank you. And so while we're waiting on a couple of questions, I did want to just reiterate, I think Dr. Wakim, as he was able to give an example of what's happening at the community health center level, I think what's really important for us to recognize is truly there are a lot of barriers in providing really great oral health access to the patients, and especially those in public housing. But I think one of the things that we learned even through their model is that the collaborative efforts and the partnerships that they have been able to build, not only with the medical team but other organizations in that community, have really done a lot to really improve that overall access and the quality of care they're able to provide. And we see that a lot of our health centers are actually trying to get into teledentistry of some form. And you know, as you've heard from all of our presenters, at the federal, state, national, and local levels, there are numerous resources that are accessible to U.S. community health centers that you can really tap into to provide this care. So one of the first question that we're going to take that came in is, what advice do you have for health center programs on how to retain dental staff?
Actually, if you go, that's a very long topic, but if you go to the NNOHA website and you look under practice management resources, we have a six chapter series on dental clinic, health center, dental program, clinic management, and one whole chapter is devoted to workforce. And if you go into the workforce chapter, it talks about staff retention, both of providers and of team members, and the facilitating factors that keep people working at health centers and don't. And there's another related, again, if you go on the website, we did a survey. Every 5 years we do a survey of providers, dentists and hygienists, a salary survey, but it also covers satisfaction, practice satisfaction factors. And so if you look at those two resources, that will give you some beginning points on what keeps people working at health centers.
Mm-hmm.
Dr. Webb, I don't know if my mic is on.
Sure.
Yeah, what I was going to say is also just having realistic expectations from the beginning, is a good thing. And for us, we also utilize part-time providers, which is great because we have a lot of providers that are in private practice that come and work with us, on a part-time basis. And I'm always happy to have them come and, chip in, so to speak, because it helps us kind of, reinforce the fact that our quality is basically the same as the quality of private practice. So.
Excellent input. Thank you. The second question that we have is, given the connection between oral health and the development of chronic diseases in older populations, is some level of basic care being considered for Medicare beneficiaries? And I think that,
yeah, I think I'll take that one. And unfortunately, the answer is no. I'm not hearing that discussion at the federal level. Now, I would hope that the awareness that we're raising among policymakers is going to have some effect, but that's about the best we can hope for at this time.
Okay. Well, so we're going to do our part on our end to see how much we can push these issues out. I think it's very important, especially for community health centers, that maybe we do, and sometime in the future, have something in place. We are actually, I don't think we have any more questions in the queue at this time. Do we, Devin?
That is all.
Okay, great. And we are now at 2 o'clock, and I know most of the community health centers right now on the line have taken this time out of their busy schedules because it's such an important topic, especially in the work that they're doing to impact the lives of residents in public housing. So I do want to, again, thank all of our speakers. I think this is an exceptional presentation. We will put the presentation, again, on our website at nchph.org. We will have an audio version of this recording also available. And for the presenters, all of the links that you have provided will be actually added and included on our websites as well, so that our grant will have quick access to those very, very helpful links that you shared. Also, I just want to let all of the health center grantees know that in June through the 6th through the 4th through the 6th of 2013, we will be holding our national symposium for health centers and public housing sites. In the beautiful city of Denver, Colorado. We will be doing this in collaboration with our other HRSA-funded National Cooperative Agreement, Community Health Partners for Sustainability. So we do want to reiterate that we will have some oral health topics as well at the symposium. So we would actually ask you to consider submitting your call for abstracts. They are due on January the 7th. And then what we will do is also make sure that we can continue to share information as we continue to work with all of our partners through the National Center for Health and Public Housing. So oral health is a very big issue for us. And as we heard from one grantee who kind of represents the family of grantees, and as you've heard from CMS, as well as our the National Network on Oral Health Access, there's a lot that's been going on in this area, and there is a lot that we have seen improvement over the years. So hopefully we can achieve all of our goals for not only HRSA, but also our national goals on oral health access and improvement across the country. So thank you again to the presenters for your time, for your expertise, and for the partnerships with North American Management. Thank you everyone for joining today's call.